Well, good morning. So today I'll introduce you to my PhD topic, which is conservative therapeutic approaches to restore dental enamel. And I'm Bianca Golzio, and my main vision is to translate the clinical problems that we have to high-level science, especially through the minimally invasive dentistry. So my mission is basically to truly bring to clinical practice these possibilities. So my main goals are to achieve this mission through these two projects. And the first one that I have, and I'm going to show you today, is the efficacy of CPP-ACP on white spot lesions. So just a quick background, until the 90s, there was a reduction of 90% in the caries experience, especially in high-income countries, due to the widespread use of the fluoridated toothpaste. Despite of this, according to global burden of diseases, untreated dental caries is still the most common health condition that we have. So there's 2.3 billion people who have caries of permanent teeth and 530 million of children who have caries of primary teeth. Thus, there's a need to develop and enhance the efficacy of fluoride, especially in early stages of caries. So that's why CPP-ACP could be a product for that. It is derived from the milk protein casein, it offers no harm, and can reduce up to 58% of lesion area after 4 weeks of use. That's why our aim is to evaluate the remineralization efficacy of the combination of CPP-ACP and fluoride. So our clinical question is if this combination is in fact more effective than using fluoride alone, especially in the early stages of caries. So this is our PICO frame, and our hypothesis is that this combination is more effective. So this is a systematic search that we have done in the main databases. And here's the selection where we were left with 16 eligible full texts. And then to measure the remineralization, we mainly have these two methods. The first one is the laser fluorescence through the diagonodent, which is a device that uses a red laser through this tip that is touched to the tooth surface. And then we can have a fluorescence value that is done to a scale of 0 to 99, as we can see here in this canary scale. And usually 0 to 10 represents a healthy tooth structure, and 20 is the maximum value to consider as the early stages of caries. So this will be our maximum value that we will work in the results. And for the KLF, it is a method that combines the blue light and also this intraoral camera. And they both together, they can have these images that we can see here, the fluorescent images. And through a software, we can measure the fluorescence loss, which what we want to see with this fluorescence loss, it means the demineralization. So what we want to see is the gain of mineralization, so the gain of fluorescence. And we can also see the area and also the volume of the lesion of the caries. So we can also see this through this device, as we can see here in this table. And the first results that we have is the laser fluorescence. These results are mainly calculated by the difference between the given time points that we will have minus the baseline values. So we will have here the mean is this difference. And here we can see the LF value for the first month. We can see a high heterogeneity here with 94%, and this is mainly due to the differences in the population, so the age difference, also the methods of application, and the type of white spot lesion is very different. And from the common effect, we can see minus 0.40, which is statistically significant compared to the control group, but still clinically is not significant, as we can remember from the LF scale, which ranges a lot. So from the second, still LF, but now 3 months, now we can see still high heterogeneity, but then a common effect of minus 0.59, which now is not statistically significant, but we can still see that there's a tendency to favor the CPP group, except from these two underlying studies. So the first one uses a different scoring system, and the second one actually used the CPP-ACP weekly, while the fluoride was used daily. So this could be a reason for these different results. And then for the 6 months, we had only 2 studies, so the heterogeneity was still high, and we had a common effect of minus 0.46, which is not statistically significant nor clinically. And for the KLF, we had for 1 month only 3 studies, and they were not heterogeneous. But we can still see a 0.21 of common effect, which is not statistically significant nor clinically still. And in the 3 months, we can see a different result now. We can see still a low heterogeneity, but we see a 0.58 of common effect. And actually, it is statistically significant, but now favoring the control group. And this could be explained because the Albatane study actually used the CPP not in a way that was recommended. So this might have hindered the CPP-ACP effect, and this could be a reason for it. And now the QLF for the 6 months, now we have a higher heterogeneity, but still moderate, because there's a different combination of the previous studies. But still we see a common effect of 0.60, where it's not statistically significant nor clinically significant. So our main conclusion is that the combination of CPP-ACP and fluoride could achieve mainly the same effectiveness as fluoride alone, but did not overcome it, even though it showed at some points a tendency to favor the CPP-ACP group, especially in the LF values, but not in the QLF. So also the CPP-ACP shows a tendency to have better results than the CPP-ACP for non-daily use. So the use of fluoride inside the product actually provided a better result for non-daily use. And in the daily use of the fluoride toothpaste, it also showed a better tendency than the sporadic use of the CPP-ACP, which is a very important outcome that we can see now. And to finish the conclusion, also the younger children tended to show better results when using fluoride toothpaste only. So our main strengths is that we use only RCTs. We did the analysis by time points, differently from other methods previously done. And we did a measurement based on the differences between baseline and the given time point. So our limitations were the short follow-up time, the high heterogeneity of the studies, and also the low number of studies and patients that we had. And our main implication for practice is that this combination could moderately improve the efficacy of remineralization if following compliance and in high-risk patients, but mostly the reinforcement of the oral hygiene through the fluoride toothpaste provides already the remineralization of those lesions. So for research, further studies are needed with a longer follow-up time and following also a more consistent methodology, and also the development of better products are needed to achieve better results. So the second topic is the role of CPP-ACP on molar hypomineralization. So MH is a qualitative developmental defect of the enamel that ranges from severity and also discoloration. So MH has a global prevalence of 12.9%, and of MH-affected teeth, 27.4% did or will require the need for treatment, mainly due to pain and sensitivity, but also post-eruptive breakdown. So due to the remineralization potential of the CPP-ACP, we believe that it could reduce these two complications that these patients have. So our aim is to understand to what extent CPP-ACP can really increase the mineral content and reduce the hypersensitivity. So our clinical question is if CPP-ACP is effective on those two outcomes, and we would compare the after and before treatment. So our hypothesis still that CPP-ACP is effective on increasing these, and our clinical implication is the improvement on managing the patient's treatment and also preventing further complications that these patients might have through an easy and safe approach. So this is our systematic search that has been done, and this is a summary of our plan to finish those two studies by May and July respectively. And I'd like to thank you for your attention and leave you with this quote: you can't go back and change the beginning, but you can start where you are and change the ending. So thank you very much.
Thank you very much for your nice presentation. And I have a question connected to your first topic. Do you think Diagnodent, so it's a device, a measuring device, do you think it has any bias on your study?
Yes, of course, because when we think of diagnosing caries, the most common is the visual examination. So other devices that you can use especially these two, since they measure different things in a sense, even though they're both used to measure remineralization in the studies. But for example, LF measures the byproducts of the bacteria, while the KLF actually measures the mineral loss. So it's a different way that they measure, so this could have a bias in the results, and this could explain why LF shows a tendency to favor, while KLF doesn't. So we should further understand this.
Thank you very much.
I also have a question about your first article. As far as I assume they are coming from many different countries.
Yes.
Do you think different diets could have had a significant effect on the outcomes? If so, do you think it did?
I don't think the main problem, we have so many possibilities of limitations that the diet could also be one, but we have also the difference in the age of these groups. Some patients, the adult ones, they applied by themselves. The younger ones was applied by the teacher, and then they had a school, vacation, and then it was the parents. So there's a lot of limitations between the use itself, and also some studies reported that during the follow-up time, the patients reported that they left the use of the CPP-ACP, so they just kept using the fluoride toothpaste, and they didn't use the CPP-ACP anymore. So there's a lot of reasons, and maybe diet could be one, but I don't think it could be such a strong one like the other ones.
Thank you very much. It's a very practical project for me, the first one. And so how about the cost effectiveness of these two methods, like combined one or single intervention? And so, of course, after this meta-analysis published, it's going to be very useful for any different countries. And so they're going to read this. And what about the cost effectiveness? Thank you.
Of course, with the results that we have, it's not cost effective to use two products if we could show that they mainly had the same results. So with these results of this meta-analysis, even though we have several limitations with the studies, but for now, we cannot say that it's cost effective. So that's why we need to have further studies that have a more consistent methodology, so we can really understand what are the reasons behind this and if it's really effective or not.
How to use this agent? Could it be put into a toothpaste, or should it be ingested, or some kind of other way?
It's very easy to use. So you basically just apply in the surface of the teeth. You can just apply with your finger after you brush your teeth with a regular toothpaste. And then you should leave it there for 2 minutes. And then you shouldn't rinse and not eat and not drink, at least for the first 30 minutes. That's why there's this small little details that maybe the patients didn't follow through, especially if we can imagine very young patients with 2 to 3 years old at the school, and maybe the teacher did wait or not. So there's a lot of limitations with this.
Thank you.